Hello, my name is Alison Greene, and this is a virtual presentation for the SAGES 2020 virtual meeting. My abstract is titled, A Randomized Controlled Trial Comparing Right and Left Lateral Starting Position and Outcomes in Colonoscopy. The authors of this study have nothing to disclose. Patient positioning in colonoscopy has been proposed as a simple and inexpensive technique to increase luminal distension and improve mucosal visualization. Colonoscopy utilizes both air and water during the procedure. Air rises and water tends to go to the dependent areas of the bowel. Changing position changes the dependent area of the bowel, allowing air to fill the non-dependent segments of the bowel and increases luminal distension in these segments. This allows for easier navigation of the colonoscope and improved comfort for the patient. This strategy has been proven to be useful during colonoscopic withdrawal, as the use of prescribed position changes has been shown to improve mucosal visualization and adenoma detection rates. Take, for example, this colon. Given that air rises, the right colon will be most distended with the patient in the left lateral position. The transverse colon will be most distended in the supine position, and the left colon, and in particular the sigmoid colon, will be most distended and best visualized in the right lateral position. As the sigmoid colon is often the most challenging segment of the colon to navigate during a colonoscopy, it would make sense to start the procedure in the right lateral position to fill the left colon with air. In the right lateral position, air rises, fills the sigmoid colon with air, and increases luminal distension. This allows for improved visualization, making navigation easier, and improving patient comfort. This concept has been studied previously with several RCTs looking at position change, and in particular, right lateral position as a starting position in colonoscopy. Several of these studies have shown that the right lateral position decreases cecal intubation time and improves patient comfort compared to the gold standard left lateral position. These findings, however, have not made their way into current practice. So we hypothesized starting a colonoscopy in the right lateral position could improve visualization by increasing luminal distension. This would decrease cecal intubation time and improve patient comfort. To do this, we designed a randomized controlled trial that would compare outcomes in colonoscopy in patients starting their colonoscopy in the right lateral decubitus position compared to the standard left lateral decubitus position. The primary outcome was time to cecal intubation comparing the two starting positions. We defined cecal intubation time as the time from the first visualization of the rectal mucosa to the identification of the three cecal landmarks: the triradiate fold, the appendiceal orifice, and the ileocecal valve. The secondary outcomes included cecal intubation rates, ADR, sedation dosage, the number of position changes, and the amount of water required to reach the cecum, and the NAPCOM score. The NAPCOM score is a validated scoring system for pain in patients undergoing colonoscopy that is assessed and recorded by nurses during the procedure. It is a standard practice in the colonoscopy suites included in this study. Our inclusion criteria were all patients presenting for their scheduled colonoscopy at two university-affiliated endoscopy suites in St. John's, Newfoundland. And our exclusion criteria were people who had undergone a previous bowel resection, those that had an MSK problem that stopped them from lying on one side or turning during the colonoscopy, and patients who refused to participate. A total of 172 patients were needed to power the study. All endoscopists who had completed the CSI course, which is under the umbrella of the Canadian C program, were included in the study. This included 8 gastroenterologists and 5 general surgeons. Trainees were excluded from the study. Patients were taken to the endoscopy suite and consented to take part in the study. They were randomized to the right or left lateral position using sealed opaque envelopes to reveal the randomization. They were then positioned by the endoscopy staff, and the colonoscopy took place as usual. Trained personnel were in the endoscopy suite for data collection. Nursing records were used for the NAPCOM score and for the dosage of the sedatives. This consort diagram depicts the randomization of patients in the trial. A total of 221 patients were approached to take part, with 26 patients being excluded due to either previous colonic surgery or refusal to participate. There were 5 incomplete colonoscopies in each group. 91 patients were included in the analysis of the left lateral position, and 94 patients in the analysis of the right. Table 1 shows the demographics of patients included in the study. There were no differences between the two groups. The mean age was 60, the mean BMI was 28, which was a higher BMI than those reported in previous studies. We used a variety of statistical analysis where appropriate for this data. Univariate regression and multivariate regression analysis was used to identify variables associated with the primary outcome. All analyses were done using version 25 of the SPSS statistics program. This is the univariate regression analysis for time to cecum. Factors with a p-value less than 0.1 identified to be independently associated with time to cecum. These included sex, previous surgery indication, the adequacy of the bowel preparation, the specialty of the colonoscopist, either general surgeon or gastroenterologist, the experience of the endoscopist, greater than or less than 5 years in practice. Also, NAPCOM score, the dosage of midazolam used, the amount of water used, and the number of position changes were identified using Pearson's correlation. Table 3 depicts the multivariate regression model for time to cecum analysis. This identifies sex, specialty, experience, NAPCOM score, total water use, and the number of position changes needed to reach a cecum as the factors associated with time to cecum. The R-squared for this model was 0.708. This table shows the secondary outcomes comparing the right and left lateral starting positions. There was no difference identified for any of the secondary outcomes except for the amount of midazolam, with more midazolam used for patients starting in the right lateral position. Contrary to previous studies, we found no difference in time to cecal intubation comparing the right and left lateral starting positions. While starting position had no effect on the time to cecal intubation, the model developed from this study accounted for a large amount of variation, indicating that the most important variables were included. Similar to previous trials, this model identified female gender as the only demographic factor associated with longer cecal intubation times. It also identified the NAPCOM score, the amount of water used, the number of position changes as being associated with longer times. These associations are not surprising, as colonoscopies with longer insertion times tend to be more difficult for both the patient and the endoscopist. Additionally, general surgeons and having less than 5 years of experience were associated with longer insertion times. These findings are consistent with the literature. No difference was found in any of the secondary outcomes comparing the right lateral and left lateral starting position. This included differences in patient comfort. The significance of midazolam is small and may not be clinically significant. All endoscopists who took part in the study had extra training with the colonoscopy skills improvement course. This program taught multiple techniques for patients positioned in the left lateral position. It also encouraged the use of water as opposed to air during colonoscope insertion. Therefore, there may have been an unfair advantage using the left lateral position compared to the right lateral position. We initially had included only these endoscopists to improve external validity, which we thought was a strength in the study. However, it is possible that we introduced bias into the study because of this program. Based upon the findings of this study, we question the utility of using a right lateral starting position for colonoscopists who have previously taken an upskilling course promoting the use of early position change and water infusion. These are my references, and I'd like to thank you for listening to my presentation. If you have any questions or comments, please direct them to my email at amgreene@mun.ca.